Okay, good day. We are down to our second to the last topic. Our topic this morning is on endometrial hyperplasia and endometrial carcinoma. Endometrial carcinoma is the most common gynecologic malignancy in the United States and the third most common gynecologic malignancy here in the Philippines. It is the most common malignancy detected in postmenopausal women at around age 62 years old. So again, age is a very important factor also as a risk of the development of endometrial carcinoma. There are two types or two categories of endometrial carcinoma. One is the estrogen dependent, while the type 2 is non-estrogen dependent. In other words, type 1 develops because of the influence of estrogen, while type 2 develops outside the influence of estrogen. So the more common type is the type 1. 80 to 90% of endometrial carcinoma belong to type 1, and a good example of this is the endometrioid adenocarcinoma. While for type 2, these are the serous and the clear cell adenocarcinoma. These types have poor prognosis in comparison to type 1. This is not in your book. I found this, or I got this from a pathology book as our reference also. So I think it's important for you to know the difference between type 1 and type 2. The type 1 is because of unopposed estrogen, as I mentioned earlier, contrary to type 2. While tumor grade for type 1 is more commonly low, while high grade for type 2. Myometrial invasion, oftentimes minimal, while for type 2, it's deeper. And so metastasis, the risk of metastasis is higher in type 2 histologies, such as serous and clear cell adenocarcinoma. As I said, type 2 is more aggressive than type 1. And because we are into genetics now, there is P10 mutation in type 1, while P53 mutation in type 2. This is the more important factor that we should remember when we talk about endometrial carcinoma. So what's the physiology? So before, again, going to pathology, let's review physiology first. You know, I got this illustration from a student who took my exam also, and I was impressed on how he was able to organize his thoughts when I told them to create a diagram on the menstrual cycle involving not only the HPO axis, but including the endometrium. So each of these boxes has a point. So just to review, the GnRH comes from the hypothalamus, influences the anterior pituitary. And so the anterior pituitary releases the gonadotropins FSH and LH. Now, depending on the phase of the cycle, the FSH function is to produce one dominant follicle. And the hormone product of the follicular phase is estrogen. And estrogen causes endometrial proliferation. Thus, when we call the cycle in the ovary, we call it follicular phase. As you go to the endometrium, we call it the proliferative phase. Now, while in the second half of the cycle, it's predominantly the LH because it's the inhibin that inhibits the FSH. Therefore, with high estrogen output, there is stimulation of more gonadotropin release, but because of the inhibin, FSH is lesser in comparison to LH. So LH surges, and once the LH surges, ovulation happens. And so once ovulation happens, the follicle from where it ruptures becomes the corpus luteum. And the predominant hormone in the second half of the cycle is progesterone, although there is still a small amount of estrogen and inhibin. The corpus luteum dies at approximately 14 days. And so once it has reached its lifespan, progesterone, estrogen, and inhibin is withdrawn, majority progesterone. So as the hormones are withdrawn, then there is spiral arteriolar spasm, then menstruation follows. Again, the role of progesterone counteracts estrogen. And so if estrogen is endometrial proliferation, progesterone is secretory in function. That means without the progesterone, estrogen keeps on proliferating the endometrium. That is why it is very important for a woman to ovulate so as to produce the corpus luteum that produces the progesterone that counteracts estrogen. So we call the second half phase, as in the ovary, we call it the luteal phase. In the endometrium, we call it the secretory phase. So you should not interchange. Again, ovarian, follicular phase before ovulation. Endometrial, proliferative. Okay, how about the after ovulation? What do you call the ovarian phase? Luteal, while endometrial, secretory. There are only two goals of the ovarian cycle, as I mentioned earlier. One is to produce one mature follicle with the function of through the function of the follicle stimulating hormone, and steroidogenesis from the function of the luteinizing hormone. What steroids do the ovary targets produce? Of course, the two popular, estrogen and progesterone. So as you can see here, there is a pulsatile GnRH release, stimulates release of gonadotropins in the anterior pituitary, the FSH in the granulosa cell, aromatization occurs through the function of the FSH. What is aromatization? It's converting androstenedione to estrogen. Without FSH in the cytochrome P450 enzyme, aromatization does not happen. Okay. Now, what's the role of the theca cell? The theca cell just helps provide more substrate of androstenedione to the granulosa cell to produce more and more and more estrogen. Okay. Now, the main substrate is cholesterol converted into androstenedione, androstenedione converted to estrogen through the process of aromatization. Again, what gonadotropin drives aromatization? It's the follicle stimulating hormone. So this is another diagram just to show you the HPO axis. The endometrium is not involved in this illustration. Depending on the phase of the cycle, in the first early follicular phase, the high estrogen level, provides negative feedback to the hypothalamus and the anterior pituitary. Why? So that only one dominant follicle will be formed. Now, once the dominant follicle is formed, then more receptors are there. Not only estrogen is being produced, it's high output estrogen from the two-cell synthesis. What was the two-cell synthesis I was telling you? It was the granulosa with the help of the theca cells. The theca cells provide more substrate of androgen to the granulosa cell to produce more and more and more estrogen. Therefore, high output estrogen again is necessary to produce a positive feedback, stimulating the hypothalamus to release the GnRH. Since the GnRH stimulates the anterior pituitary, both FSH and LH are being released. However, inhibin is also produced by the granulosa cells. Therefore, the inhibin inhibits FSH release, while there is surge of the luteinizing hormone, and it is the surge of the luteinizing hormone that is required for ovulation. Again, high output, LH surge, ovulation. What is the end product of follicular phase? Again, what hormone? Estrogen. Now, there are types: estrone, estradiol, and estriol. Estrone, menopause. Estradiol, non-pregnant reproductive age female. Estriol, primary estrogen of pregnancy. Now, high output estrogen is needed to ovulate, so to cause LH surge here, okay? Again, high output estrogen, LH surge, ovulation happens. Without high output estrogen, no LH surge, no ovulation happens. So what if no ovulation happens? Then there is no progesterone release. Okay. So again, this is how the two-cell synthesis looks in your book. The theca cells help provide substrate of cholesterol to the granulosa cell. The granulosa cell has receptors for FSH, while the theca cells receptor for LH. But at the second half of the cycle, there is loss of the basement membrane. Both theca and granulosa are well nourished with blood vessels already, and so there is easier transport of substances, producing more steroids. So if in the first half is just estrogen, in the second half, progesterone. Now, okay, the same substrate, cholesterol. Okay, just showing the difference. All right. There. Okay, histologically, we should be able to identify the parts or the layers of the uterus. So the innermost is the endometrium, okay, the endometrial lining. Depending on the phase of the cycle, the thickness varies, while the next after the endometrium is the myometrium. And of course, after the myometrium, what's the third layer? It's the serosa or the visceral peritoneum. Either term you can use, it's the same. Okay, so the functionalis layer, again, we go back here. Endometrium has stratum functionalis and stratum basalis. There is the compact layer and the spongy layer for stratum functionalis. Oh, there, okay? Functionalis layer, basalis layer. Depending again on the phase, proliferative phase is the thinnest time of the cycle, because again of the sloughing off that happens during menstruation. But as the days of the cycle progresses, the endometrium thickens, showing us secretory glands. So this is the high power view of the proliferative phase. We see basally located nuclei, okay? Glands are uniform, okay? This is the lining of the endometrium, simple columnar, and these are the glands, okay? Proliferative phase. Follicular phase estradiol production is the most important factor in endometrial recovery, regrowth following menstruation. Both ER alpha and ER beta are expressed in the endometrium. Again, the product of the follicular phase is estradiol. Endometrium is usually less than 2 mm thin during the proliferative phase. That is why during the proliferative phase, this is the most ideal time that we would do a transvaginal ultrasound for us to be able to visualize if there are other abnormalities such as polyp or small submucous myoma, if you are entertaining or we would like to rule out other gynecologic pathology. The glands are narrow tubular structures that pursue almost a straight and parallel course from the basalis layer toward the endometrial cavity. While the secretory phase, after ovulation, the estrogen prime endometrium responds to rising progesterone levels. So this is the proliferative phase, not yet very thick. This is estrogen prime. Then with rising progesterone levels, the proliferated endometrium becomes secretory. There. Okay. So progesterone, as I mentioned, it antagonizes the mitotic effects of estrogen by decreasing estrogen receptors and by increasing progesterone-specific enzyme 17-beta-hydroxy dehydrogenase, which converts estradiol to a much less active estrone. So that means from a 4 mm during the proliferative phase to approximately about 12 millimeters at the time of ovulation. So again, weaker form. Now, on day 17 of the cycle, we will be able to appreciate glycogen accumulating at the basal portion of the glandular epithelium, showing subnuclear vacuoles. And these subnuclear vacuoles are the first histologic sign of progesterone effect. Then, as the days progresses, the vacuoles move to the apical portion, and then glycoprotein. So as the vacuoles move to the apical portion, it becomes secretory, secreting glycoprotein and mucopolysaccharide to the gland lumen. Now, at day 21 to 24, we also would be able to appreciate the edematous stroma here. Okay. So it's very evident. And so the next, you will also appreciate that the glands look like sawtooth already. So here, this is the subnuclear vacuoles. So there is already an effect of progesterone. So what phase? Secretory. Now the glands are still tubular. Okay. The lining is still thin. So this is proliferative. So in our topic, we will be able to appreciate the abnormal if we understand what's normal. So the normal glands should not be too close to each other, and there should be no mitotic figures. There should be no increase in nuclear to cytoplasmic ratio. The nucleus should still be at the basal area, or yes. So there. As you can see here, the glands start to crowd, okay, as we progress in the pathology. Okay, there. What are then the risk factors of hyperplasia? What do you see in the picture? Obesity. It is the most common cause of endogenous overproduction of estrogen. Apart from it being a source of overproduction of estrogen, it also decreases the sex hormone binding globulin. So if there is a decrease in the sex hormone binding globulin, there is no more chaperone for the hormone estrogen. So what happens? The estrogen becomes more bioavailable. There is also increased insulin resistance among obese patients. Therefore, this gives us a 2 to 3-fold increased risk of endometrial carcinoma. So what happens with obesity? So high cholesterol, of course, and remember the cholesterol is the substrate, diba, of all the steroid. But in the adrenal glands, you will see how these are converted using the enzymes, with the help of the enzymes. So it produces, as I said, androstenedione, testosterone converted into estradiol. Okay, where in the ovaries already aromatization occurs in the ovaries. Specifically, where in the ovary? Granulosa cells. Okay, pathophysiology of obesity-induced, and also hyperinsulinemia because of insulin resistance. So what happens with a risk factor of obesity? So there is increased aromatase activity in the periphery or in the fat cells. Remember, not only does the aromatase function in the ovary, but it also functions in the periphery, specifically in the fat cells. So more fat cells, more aromatization of androstenedione to estrone, a weaker estrogen. So here, this is the illustration of how in the periphery, androstenedione is converted into estrone and still act on the target organ, endometrium, uterus endometrium. So another pathophysiology, apart from increased aromatization in the fat cells, there is also high androgen in the adrenal and in the ovary. So as I showed you earlier in the previous slide, in the adrenal gland, cholesterol is the substrate. And so in the adrenal, there is more production of androgen. However, even if androgen is a substrate for the production of estradiol in the ovary, if there is too much androgen, there is inhibition of the aromatization. So what happens instead of aromatization? It does not occur. It does not produce estrogen. In fact, it becomes reduced, becomes a 5-alpha reductase, and so producing more and more and more androgen, giving us a hyperandrogenic state. Hyperandrogenic state, hyperandrogenism is presented in 3 clinical manifestations. 1, hirsutism. 2, the opposite, hair fall. And 3, acne. Okay, this is how aromatization supposedly happens in the granulosa cells. But because of very high androgen, 5-alpha androgens are produced with the help of the 5-alpha reductase enzyme, and in estrogen production is being inhibited. What happens in postmenopausal women? I already mentioned sex hormone binding globulin, right? If there is decrease in the sex hormone binding globulin, it's just like we are losing the chaperone. And so, when a teenager does not have a chaperone, they become more wild. Joke. So more or less, it's like that. If there is no sex hormone binding globulin, even if the hormones are not much, but they are bioavailable, so they become more active. So what happens in the postmenopausal women? So the example or the pathway I showed you was for reproductive age women, but what about for postmenopausal women? Why is it still a risk factor to become obese when you are in the postmenopausal stage? In the postmenopausal women, there is no more ovary. So the ovary is not functioning anymore. Therefore, there is no more source of estrogen and progesterone because, again, only the ovary produces a balancing hormones, estrogen and progesterone. But if a postmenopausal woman is obese, then there is still a lot of fat cells. And of course, the adrenals are still working. So what happens in the fat cells? Increase aromatase, and in the adrenal, high androgen amounts. So unopposed estrogen will influence the endometrium even during a postmenopausal women. So these are the enumerated increased risk. I keep mentioning unopposed estrogen stimulation, estrogen replacement therapy, menopause after 52 years old. There is a 2.4 times increase in the risk. Average Filipina woman, the age of menopause of an average Filipina woman is between 47 to 48. And so a menopause of 52 is already late menopause. And another risk factor is early menarche. Why? Early menarche and late menopause exposes a woman longer to estrogen. Obesity, I keep repeating already, with high fat content. Nulliparity, because it's associated with anovulation. So if a woman has unopposed estrogen, or estrogen is high but not high enough to produce ovulation, then there is no progesterone. Therefore, nulliparity and infertility also increases the risk. Diabetes, hypertension, insulin resistance, these are related comorbidities. Estrogen secreting ovarian tumors. I think I have mentioned this in one of the causes of hyperplasia. When the ovarian new growth produces estrogen, then it still influences the endometrial lining, causing hyperplasia. One example is the granulosa cell tumor. The granulosa cell tumor is a sex cord tumor that secretes estrogen. Now, as this ovarian new growth secretes estrogen, it acts also on the endometrium. And usually these patients come in with abnormal vaginal bleeding and a palpable ovarian mass. Okay. Polycystic ovarian syndrome, because polycystic ovarian syndrome has three: anovulation or irregularity of menses, amenorrhea or oligomenorrhea, high androgen, clinical manifestation, acne, hirsutism, alopecia, and lastly, polycystic appearing ovaries. So those are the three criteria for polycystic ovarian syndrome. And again, there is unopposed estrogen in PCOS. Risk also is women who are in tamoxifen therapy for breast cancer. Okay, for these women, we should have a baseline imaging already, because we know that tamoxifen can cause hyperplasia or thickening of the endometrial lining. Also worth mentioning is the Lynch syndrome. This is the hereditary type. This is familial. There is colon carcinoma, endometrial carcinoma there. Okay. How about what factors diminishes the risk? Of course, opposite to an ovulation. A woman ovulates every month. Her cycle are regular. Difference in the interval is just 2-3 days, the maximum. Progestin therapy, because again, if the pathophysiology is unopposed estrogen, so progestin therapy given will counteract the action of estrogen. Combination oral contraceptives, because OCPs, because of the exact amounts of hormones already in the combined oral contraceptive, then there is controlled proliferation and sloughing off of the endometrium. Menopause before 49, as I said, average age 47 to 48. Multiparity also, because when you become pregnant, you are not exposed to estrogen. What is the predominant hormone for pregnancy? Pregnancy, progesterone. So in pregnancy, progesterone should be the predominant hormone, and so lesser exposure to estrogen. So the more children, the more protection it gives, because apart from the 9 months of pregnancy, if a woman is breastfeeding, all the more there is lesser exposure to estrogen. I put an asterisk of smoking, because smoking gives us a hypoestrogenic state. However, again, benefits should outweigh the risk. You should weigh it very much if, you know, you would want smoking to diminish the risk of endometrial carcinoma. Endometrial hyperplasia is the only known direct precursor of invasive disease. Endometrial thickening with proliferation of irregularly sized and shaped glands with increased gland to stroma ratio. So If this is the normal endometrium, see, it's thin. Now in hyperplasia, it's quite thick. But important to note, there is no invasion. So gland to stroma ratio, this is the gland, this is the stroma. So as you can see, as it progresses, there is loss of the stroma and increased number of the glands. According to the World Health Organization, there is simple, complex, atypical simple, and atypical complex. So this is simple hyperplasia. There is only 1% progression to cancer. Again, simple hyperplasia, only 1%. Look at again the glands and the stroma. Now there is more crowding, but yet there is no atypia. So this is complex hyperplasia without atypia. There is 3% progression to cancer. While for atypical or atypical hyperplasia, then there is 29% progression to cancer. We don't have atypical simple hyperplasia anymore. Just simple, hyperplasia without atypia and atypical hyperplasia. So clinical features and how to diagnose. This is a picture of an ultrasound measuring the endometrial thickness. So endometrial thickness is a very important detail for us to identify whether there is hyperplasia or no, none. So cystic spaces will also give us a clue. So when to do endometrial biopsy, remember this four. More than 48 years old, so older women with abnormal uterine bleeding, you do endometrial biopsy. Or women less than 45 years old but has risk factors such as chronic excess estrogen exposure, failed medical management, and persistent AUB, even with medical management, so failed medical management. Third is asymptomatic postmenopausal woman with endometrial thickness of more than 5 millimeters. So again, a endometrial thickness of a postmenopausal woman should be thin. It should not be thick. So the cutoff is equal to less than or equal to 4 millimeters. This thickness of less than 4 millimeters is 100% has a 100% negative predictive value, meaning when endometrial lining is less than or equal to 4 mm, there is 100% man. So it's 0 chance of malignancy. Although bleeding can be attributed to endometrial atrophy. Now, do we do endometrial biopsy among tamoxifen users? Only, yes, but only among those with bleeding. Again, we don't do endometrial biopsy to all tamoxifen users because as expected, there is endometrial thickness. That's why it's important that we do a baseline transvaginal ultrasound to look at the endometrial thickness before starting tamoxifen. Now, since it's expected that the endometrial lining is thickened due to the tamoxifen use, we only do endometrial biopsy if a woman is symptomatic or she experiences bleeding. So, do we do endometrial biopsy in a 30-year-old obese class 1 with amenorrhea for the past 3 months but currently profusely bleeding? Yes or no? It's a go. Yes. 22-year-old bleeding for 2 weeks. After 3 months of amenorrhea, 22, negative pregnancy test and the transvaginal ultrasound with endometrial thickness of 10 millimeters. Again, this is less than 45 years old, but still very young. So chances of endometrial carcinoma very low. So medical management first. 34 years old, breast cancer on tamoxifen and complaining of vaginal bleeding. What did I just say? Tamoxifen symptomatic, go. 38 years old, also breast cancer patient on tamoxifen. TVS finding thick endometrium but no other complaints? No, stop. We don't need because she is asymptomatic. 58 years old on executive wellness checkup, noted to have an endometrial thickness of 4 millimeters. No other complaints. 58, 4, stop. Or no need to do endometrial biopsy, just wellness checkup. And 4mm has 100% negative predictive value. 51 years old, post-menopause, 18 months ago, noted vaginal bleeding. A week prior to consult, but no recurrence. TVS showed a 3mm endometrium. What did I say again? Less than or equal to 4mm. 100% negative predictive value, so no need. 60 years old, brownish to reddish discharge, spotting to minimal that is persistent for 3 weeks. Persistent, that's the key word there. Look at the age, so go. 56 years old, obese, only with that, without reading further, it's a go. Okay, 56, woman in wellness checkup bringing a TVS result with a thick endometrium, all the more, 1.3 cm. So it's a go. 25 years old, day 24 of the cycle with TVS showing a thick endometrium. Look at the age, young, and look at the day of the cycle. So we are already at the second half. So it's expected to be thick. So you don't need to do endometrial biopsy. Just tell her if you really want to do TVS, you do TVS during the proliferative phase, ideally at day 4 to day 6 of the cycle. 36 years old, newly gravid, spotting for 1 month with TVS of an endometrial thickness of 25 millimeters. Is it a go or a no? 36 years old, newly gravid. Oh, sige. It's a go. Look, she has the risk factors, newly gravid. Thick. It's very thick, 25 millimeters. It's 2.5 cm. What happened? Okay? So, very easy. Just know when to. It's part of the objectives given to us. When to do endometrial biopsy. Okay. Management, hyperplasia. We have options for medical management. Progesterone, high dose progesterone. Or here, if there is atypia, hysterectomy. Okay. Endometrial biopsy in the cervical curettage. Also, if you like to look at the if there is invasion to the cervix also, but you get the cervical tissue first before the endometrial tissue. Okay. There are different histology of endometrial primary adenocarcinoma. Endometrioid adenocarcinoma with squamous element, clear cell, serous, secretory, mucinous, and squamous carcinoma. This is how the endometrial carcinoma is staged. This is how we remember. 1, confined to the uterus. 2, invades 2, but not beyond cervical stroma. Okay? Beyond uterus, but up until cervical stroma. 3, local or regional spread of the tumor. So 3, A, B, C. Remember, A, adnexa, B, vagina, C. In Filipino, we call the lymph node as culane. So that's C. So if it's in the pelvic, that's C1. If it's in the aorta, it's C2. 4, distant metastasis, either bladder, bowel. A, if just bladder and bowel. If distant, like the intra-abdominal or inguinal lymph nodes, that's B. So distant lungs plus lymph nodes. Okay, very easy to remember. Prognostic factors, it's divided into clinical and later. So in the clinical, RAT, race, age, and tumor stage. Okay, the tumor stage is the well-recognized prognostic factor. That means if a patient is still in the stage 1, there is favorable prognosis. while the pathologic prognostic factors are tumor grade, not anymore stage, grade, grade 1, grade 2, grade 3. Okay? If less than 5%, glandular, more than, or it's a well-differentiated, intermediate, and poorly differentiated. Oh, there, it's easier. Histologic type, as I said, better prognosis for endometrioid type, tumor size, cut off 2 cm, more than 2 cm, poor prognosis, depth of myometrial invasion, less than 1/3 of the myometrium, better prognosis. Lymphovascular space invasion, of course, if there's invasion, poorer prognosis. And retroperitoneal lymph node involvement, poorer prognosis. If there is spread to the peritoneal cavity or uterine agnetha, also poor prognosis. So you should remember pathologic tumor grade, grade 2 to 3. There is a deeper myometrial invasion and there is lymphovascular space invasion, then poor prognosis. Poorest. So there are different patterns of spread. You just choose. Direct extension, lymphatic, hematogenous, and intraperitoneal exfoliation. That means endometrial cancer can spread on either way. How to treat? Surgical management remains to be the primary treatment modality. We do extrafascial hysterectomy with bilateral salpingo, oophorectomy with peritoneal fluid cytology, lymph node dissection. If there is cervical involvement, so what stage is cervical involvement? Stage 2. We do radical hysterectomy with bilateral salpingo, oophorectomy, peritoneal fluid cytology, and lymph node dissection. Radical hysterectomy, remember, this is what we do in cervical cancer. Also, infracolic amintectomy in type 2. Yes, in type 2, serous carcinoma. Chemotherapy, doxorubicin, it was the first drug identified with good activity. And it can be given as a combination, paclitaxel, doxorubicin, and cisplatin. So this is paclitaxel, doxorubicin, and cisplatin. But according to recent studies, paclitaxel and carboplatin is the first-line standard of care for advanced and recurrent endometrial carcinoma over TAP because of toxicity issues with TAP. So first-line standard care for advanced recurrent disease, paclitaxel and carboplatin. Again, paclitaxel and carboplatin. Oh, sorry. Okay. Okay, how about for intermediate, high to intermediate groups? So we give adjuvant radiation treatment to improve local disease control and recurrence-free survival rates. So clinical age, so more than 50 years old. So again, I highlighted the grade, the depth, and the lymphovascular space invasion. So again, these are very important factors that we consider. Okay, treatment. Also, you can opt for medical. Progestins, you have 4 options: megestrol acetate, medroxyprogesterone acetate, MPA, and DMPA depot, the Depo-Provera, the injectable, and of course the levonorgestrel containing intrauterine device. These are progestins. While the SERM example is tamoxifen. There are studies that say that tamoxifen works better with progestin because tamoxifen increases progesterone receptors. So progestins work better with tamoxifen. But yeah, that's just it. Aromatase inhibitor. Remember, the aromatase converts androstenedione to estrone. So aromatase inhibitor anastrozole, example. There is also temsirolimus, everolimus, and ridaforolimus, mTOR kinase inhibitors. That is the last for endometrial carcinoma. But I would just like to just show this table before we end, because this is the classification of uterine sarcoma. Remember, I mentioned sarcoma when we were discussing on leiomyoma. These are not the malignant, what's this? These are not myoma that develop into a malignant type. This is an entirely different entity, but it presents as a as a woman in a postmenopause. She complains of bleeding, and upon PE, there is an enlarged uterus. So just like endometrial adenocarcinoma, the management is surgery. Although again, there are studies that after surgery, we also give chemotherapy. Okay, again, just like endometrial carcinoma, operative stage is the most important predictive factor for survival. Just to mention, here, pure sarcoma can either be homologous or heterologous. Okay, carcinosarcoma, the mixed Mullerian tumors, Mullerian adenosarcoma, and lymphoma. Where is the endodermal? Oh, here, endodermal stromal sarcomas. Again, we look at the mitosis count, the what else? The mitosis count, the cytologic atypia, nuclear pleomorphism also. Okay, so again, the same with endometrial carcinoma surgery. By the way, the same staging also. One within the uterus myometrium, 1A if less than 50% myometrium involvement, 1B if more than 50%, 2 cervical involvement, 3 beyond the uterus but it's still within the pelvis, 3A adnexa, 3B vagina, 3C lymph nodes, 4 distant metastasis, 4A bladder rectum, 4B lungs, okay, etc. I think this ends my lecture on endometrial hyperplasia and carcinoma. Thank you very much.